All right, folks, let's go ahead and get started. Thank you all for joining us today. This is the VCU Department of Internal Medicine Grand Rounds. Today's Thursday, November 21st. As you saw in the division highlights that were just happening, this is one of our sessions sponsored by the Division of Hospital Medicine. And just as a matter of housekeeping items, please silence your cell phones and other things. CE credits are here now. They will also be on the last slide of the presentation. So appreciate that. So we are here in person downtown at the Molecular Medicine Research Building and online for those of you that want to attend. So to introduce our speaker today, let me welcome up Dr. Alan Dow, who is the Division Chair for Hospital Medicine.
Thank you, Christian. Welcome. So I'm Alan Dow. I'm the Division Chair of Hospital Medicine, for those of you that I don't know. Glad to see everyone here. Today we're going to be talking about stroke, which as a hospitalist, we see and care for a lot, but we also sort of forget it a little bit because neurology is kind of not seen as part of internal medicine. But I do think of our neurology colleagues as sort of our very close cousins. So we're excited to have our speaker and some of his also our colleagues here for it. Our speaker today is Danny Falcao. So Danny's probably well known to a lot of us. He has trained in a number of places in Florida. I'm proud to say that he's actually a residency graduate, though, from VCU. He went to South Florida to do additional training in vascular neurology. And then since he's come back, he's really been someone to champion what we do with stroke in terms of developing care pathways and following evidence, improving quality, tracking metrics. And so a lot of the successes we've had in improving stroke care, I think Danny is the person that you can point to as one of the key people for that. He does have a couple of leadership roles. He's the co-director of the Comprehensive Stroke Center and medical director of the Neurosciences Quality and Safety area. He also is the interim division chief right now for stroke. So he's a very busy and tired guy, I can say, as a former interim division chief, with how much that pulls on you. And he's actually doing work looking at how AI and augmented reality can help us think about stroke care. So it's kind of exciting to think about that, where that may go. Without further ado, Dr. Falcao.
Thank you, Alan. Thank you, everyone here. It's nice to see some familiar faces. Including Dr. Gonzalo, which I said, let's not talk about soccer today, right? Well, the goal of this talk is mainly to focus on what is the role of internal medicine physicians for stroke care, right? Inpatient hospital, right? Myself, Dr. Dennis Gervais, the co-director of the Stroke Center, Stacey Stephen, our program director there, we are working together along with a lot more team sport. So we are working together to create and develop evidence-based streamlined process for the whole health system, right? It's a stroke health system of care. Aiming to create order sets and provide evidence-based care from the door to discharge to safe transfer to the community for stroke patients. This talk came upon in this context. We have a QI project going on with Dr. McIntosh, developing for stroke care, improving the stroke DRGs, both ischemic and hemorrhagic. And Dr. Down invited me to talk to the hospitalist, and that was upgraded for the department grand rounds. But we'll mainly focus on what is the internal medicine role, and we'll discuss the evidence of it, right? So for those who are here, if you have questions, please raise your hands. I'll try to keep an eye on the chat box as much as I can, right? Ask questions anytime, right? So whenever you're faced with acute stroke, there are so many things that we should look for to obtain in terms of information, and there's always a concern for time, right? Because the time is brain. I'll explain shortly why. We'll try to obtain who is the patient. Is the patient with a history of comorbidities such as AFibs, the patient on correlation. How old is the patient? What happened? In which context you saw the stroke symptoms being developed? When, right? That's very important. Was it a wake-up stroke? Did it develop an hour ago? Was 6 hours ago? Who witnessed the symptoms? Can the patient provide history? Where was this patient was before? And do we know why? Has this ever happened before? Right. So let's do some interaction here. Right. So our first case, you have a 65-year-old woman presenting with acute onset of right-sided weakness and inability to get words out, right? So the patient is aphasic, has right hemiparesis, has here the vitals, has the typical risk factor for stroke, right? Hypertension, hyperlipidemia, diabetes, also smoking, has coronary artery disease, and the exam is showing that patient aphasic, has right hemiparesis. Now, what is the next step? You got that history, and I'll pick on our medical students that are rotating with me now. Ryan, what would you do now? Right. Now, the patient is 1 hour, 1.5 hours from presentation. Here's the head CT, no hemorrhage, right? So within that time window, we should think, patient presented to ED, what can you do to abort the stroke, to treat that patient acutely? And we'll pick thrombolytic, right? Patients within that window for IV thrombolytics and not meeting eligibility criteria, there's no obvious exclusion criteria. All right, but which one? Right? It's not that clear cut anymore, right? Which one? You pick autoplays or tenectoplays. So we'll talk about that. So the reason that I was mentioning that it is so paramount that we treat stroke in the hyperacute phase, because once the stroke ischemic core tends to develop, you see this study was published in 2006, but it's still very relevant, right? So for every minute of ischemia, you are seeing about 2 million neurons being destroyed. So you have somebody who is fully independent, able, having the risk to momentarily after live a life of dependence. If not, if the patient survives, right? So I'll take a step back here, just to clarify some key pathophysiology in 2 or 3 minutes, right? Of the ischemia. So in a normal brain, like us right now, hopefully, looking at the brain circulation and perfusion, we would expect that a normal brain to be receiving 50 mLs per 100 grams of brain tissue per minute to maintain normal function. Now, defining stroke as a cutoff of blood supply, right? Having a clot there, have a severe stenosis, that flow will decrease. By the decrease itself, you look as the flow is decreased, there will be some expectations of damage, right? I don't know if I have a pointer here. I do. Right. Okay. I don't know if the folks on Zoom can see the pointer. So here's the ischemia, and you're having 50 mLs per 100 grams of brain tissue per minute, and you have a clot, AFib or cervical stenosis. Now that tends to decrease, right? So when it gets to around 15, that's when you start seeing the failure of sodium potassium pump. You start having loss of electroactivity. You start having, if you have EEG running, you'll start to see that slowing, right? And when it crosses to below 10, that's what you're seeing now. It's no longer a penumbra. It's no longer only ischemia, but it's infarct. It's irreversible, right? So just on our illustration here, that you have an infarct core when you have a less than 10 mLs. And that's why it is very important that you see a patient with stroke symptoms. It doesn't mean that's a static situation. The dynamics of the clot evolving are there. So you may find a patient who has a arm weakness, and you admit to the hospital, and 5 days later, as the infarct has evolved, the patient cannot walk, right? So And that's one of the reasons that if the patient is not eligible for thrombolytics, not eligible for endovascular therapy, and that's why we allow permissive hypertension, right? So you have the CPP, the perfusion, serial perfusion pressure is MAP minus ICP. So you're allowing the body to maintain high blood pressure to salvage that penumbra. All right, so let's go back to our patient. The patient presented with aphasia, right sided weakness, and eligible for IV thrombolytic, and why, right? So I'll share that with you in the simplest form. You have the FDA has approved autoplays since 1996, right? Pretty much you have the autoplays that binds to the fibrin, the clot, and activates plasminogen to plasmin, and plasmin will dissolve the fibrin clots. And this was, which commonly we play around as a clot buster medication type, right? So here's a study from Dr. Haley Clark from 1995. There was a comparison of the TPA with placebo or treatment of acute ischemic strokes within the 3-hour window. That was the study that prompted the FDA approval of autoplays for acute stroke treatment. So you have the modified Rankin scale, which is a clinical tool that assesses for disability and independence post-stroke, right? So in that study, what we saw, which was a true branch study, so part 1, part 2. Part 1 was a negative study, negative part. The part 2, that's when we saw that the patient received TPA, they had a 30% chance to partial full recovery in 3 months, right? So the expectations that when you give autoplays for acute stroke, a patient with acute stroke symptoms, is that you will see the full benefit within a 3 months window, right? And those patients, they had a Rankin scale of 0 or 1. So patients who presented within a 3-hour time window, we gave autoplays, you have a 30% chance to full recovery in 3 months, to that being defined to have no symptoms or very slight symptoms, but able to perform all duties and activities, right? Now you ask, okay, what is the chance of symptomatic intracranial hemorrhage? 6.4%, right? Okay, 6.4% chance. All right, so that was a 3-hour window. Let's go back to 2008, right? The European Cooperative Acute Stroke Study. This study was designed to verify the efficacy and safety of autoplay, same dose, 0.9 milligrams per kilogram, in a different time window, 3 hours to 4.5. Okay, so the inclusion criteria was similar, not the same, but similar. And the exclusion criteria they use was different. And they excluded patients with warfarin and diabetes, combination of use past, the glucose less than 50, and there was an age also cut off to 80 years old, right? So what we saw, we extended the window, and we saw here there was a significant benefit for the patient. They still have the majority of those patients improving the same thing, about 30%, but the hemorrhage was lower. Okay, so how can you explain that? All right, they use a different criteria. The definition of hemorrhage was different, right? So the NINDS study, any hemorrhage was hemorrhage. You see a symptom getting worse, and the ICH seen on the head CT, it's a hemorrhage. The ECAS-3, they define the hemorrhage as symptomatic intracranial hemorrhage by worsening of 4 points of an NIH stroke scale, which is a tool that we use to quantify ischemic stroke burden, and seeing a hemorrhage on the CT scan or MRI. Right? That's the definition of a symptomatic intracoronary hemorrhage. It has been maintained since that time and up to now, and that's what the Joint Commissions use to certify our stroke center and look into the hemorrhage transformation and complication. Right? I'm emphasizing that because our folks at TAP and CMH, they will rely on this piece of knowledge to document as well. Right? So the next step, autoplays or tenectoplays, we have switched from tenectoplays, from autoplays to tenectoplays in April of 2023, and I'll let you know why, right? So, but all the process that I'm telling you now is part of this QI for stroke, and everything's being mapped out. It's on Epic right now. Okay, so the inclusion exclusion criteria, it can be very tricky, especially if you cover a night shift at 3 a.m. and you don't have to remember yourself all of these details. You can pull up on Epic and see our clear inclusion and especially exclusion criteria for TPA. So for tenectoplays. So autoplays, tenectoplays, they are similar but not equal. Both having similar mechanisms of action. But one of the reasons that we changed that, right? We changed that because when you look at the studies for tenectoplays, and there are several, you can see. I'll mention them in detail. The tenectoplays advantage are few but very important, right? It has a much higher affinity to fibrin and is 80 times fold resistant to plasminogen activator inhibitor. That means that it will have a higher half-life and be a more potent blood pressure medication, IV thrombolytic, especially for patients with large vessel occlusion, right? So you have had several studies that we have reviewed every single one of them, discussed with multiple teams here at VCU. And based on those studies, we made our change also has been a recommendation by our governing bodies, the American Heart Association, American Stroke Association. So there's no significant in rates of symptomatic intracoronary hemorrhage and mortality. The efficacy remains the same for patients who without a large vessel occlusion, but there's a cohort of stroke population that presents to the hospital within the time window for IV thrombolytic. They're also found to have a large vessel occlusion, right? So there lies the benefit of tenectoplays above the TPA. So what is the benefit, right? So what we saw is a trend, especially on the extend IA. All the studies, they were looking, the design, the variability depend on the dose. And what we saw was that the 0.25 milligrams per kilogram dose, when given with a patient population with large vessel occlusion, there is a 22% chance of full recanalization, even before the thrombectomy. We saw that 2 days ago, right, on a patient with a basilar thrombus. So compared to autoplays, which is on meta-analysis have shown to have around 10%. So you have 10% for autoplays, so you get 12 more, so a total of 22% with tenectoplays. The extend IA2, it showed more of a trend of similar efficacy, but higher bleeding risks with higher dose of 0.4. And because of that, we switch using the 0.25 dose, and that's what we use all across the health system. So again, half-life is 22 minutes. Now, take this half-life with a grain of salt. So if you look at the results of studies from autoplays, half-life is about 5 minutes. You give a bolus, and then the rest of the infusion for about an hour. So it's the logistics of transfer are more challenging. The tenectoplays is just one push in few seconds, and the patient can be transferred without an infusion. But both of these medications, they can deplete your clotting cascade. They can arguably cause this platelet dysfunction. Autoplays especially can cause the factor V receptor of the platelet dysfunction as well. So you gave that medication 20 minutes, 5 minutes half-life. It's also it's a risk for endothelial toxicity. So there is a time gap that you have to observe those patients very carefully, looking for symptomatic intracranial hemorrhage. That's why those patients are given thrombolytic. They are given to ICU for Q1 hour neuro checks and follow that process. Most of our internal medicine hospitals here are not involved at that level because those patients, they'll go to the ICU, except the ones that will go to the MERCU. But if you're covering service as CMH or TAP-HANIC, you'll be caring for those patients. CMH, TAP-HANIC will be transferred here. Right. So there's some change. Most of the things will remain the same on the process here, and we've been trending carefully the symptomatic intracranial. Right. So let's go back to our case. We looked at the angiogram, and you see large vessel occlusion. Right, patient who has already been given thrombolytic. So what we saw back in 2013, there were 3 studies, if I remember correctly, is ISM3, the synthesis, and rescue. Those studies were deemed to be negative for thrombectomy, mainly because they use first generation equipment, stent retrievers, right? So from 2014 to 17, you saw this pivotal studies here, landmark studies, revealing that patients with a large vessel occlusion presenting and eligible for thrombectomy have a significant trend to better outcomes, with a number to treat of 2.6 and about 2.2 greater odds of having a better outcome compared to the population that received thrombolytic alone or did not receive, was treated medically alone, right? So we have been performing mechanical thrombectomies here at VCU since 2014. I'm not correct if I'm wrong. We have an amazing neurosurgeon here, Dr. Rive, GRC, Derivka 12, and Dr. Anu Roy working with us. And again, those patients who are eligible for thrombectomy, they will go to the neuro ICU. Now, if you ask about the time, right? Because the time is brain. We have 2 landmark studies here. We used components of these 2 evidence based here, or the protocols, to build our own protocol, but the time window is 24 hours. So the diffuse 3 was a study that looked into the efficacy of thrombectomy from 6 to 24 hours, and the DOIM was 24 hours time window, and both studies trended to have a significant outcome compared to not doing a thrombectomy when patients are eligible, right? So this is the hyperacute treatment of stroke, right? Let's take a step back here. Once these patients are admitted to a hospital, post this hyperacute or did not need to have this hyperacute, the common population that you will find here in hospital on the medicine teams, both academic medicine house staff and the hospitalist team, are patients who are admitted, not given a thrombolytic, not post thrombectomy, but nevertheless have a stroke acute diagnosis, or they are admitted with a primary diagnosis that's not a stroke, and they come to either find out the patient has a stroke or develop a stroke in-house, right? So we do have a built process for that. And that's the process that most of our hospitalists here will use, and all the hospitalists at CMH and TAP-HANIC will use. That has been validated. We have reviewed multiple times, and will contain all the components of this talk today, right? With neuro checks and antiplatelets, and you'll find everything here, even the option to consult us and our colleagues from cardiology. Also, on this project, we involved a myriad of diagnostic modalities that you'll review and you'll find on this order set as well. So let's go to case 2, right? Case 2 is you have a gentleman that woke up and was found to have slurred speech and difficulty with right lower facial weakness, and right upper extremity. So a wake-up stroke, right? Patient was found to have no LVO, not eligible for IV thrombolytic, no LVO, right? So we have a HCT, right? So that's the question. So now, what is the best choice for early secondary stroke prevention in this case? Right? Who wants to take a pick on that? All right. All right, you got it right. Yeah. Now you got it right. Yeah. So it's aspirin Plavix. So aspirin clopidogrel. Why? Right. So let's talk. Let's take a step back here. So there are two studies, right? And we'll debate here. Have a question. Ask a question now. So the two studies that were shown. One is the chance study, and the other one is the point study. Right. The chance study was designed as a multi-center controlled study. It's a study was done in China, all Chinese centers, large population, and the most common, one of the most, if the most common etiology of stroke in China is intracranial arterial stenosis, right? So this study was designed as follows: the patients with a stroke with minor stroke symptoms defined by an NIH stroke scale of 3 or less, or patients who with a TIA with high risk, right, that were treated with a combination of aspirin and clopidogrel, compared to the other arm, which was aspirin alone, had a much better outcome for stroke if that therapy was done for 21 days, right? So compared to the arm of aspirin alone, and now having just the endodontal platelet, they have a decrease of stroke risk by 32%. And with a bleeding, moderate to severe hemorrhage rate of risk of 0.33, right? 0.33 is the chance of having a moderate large hemorrhage, and it has a decrease of risk of stroke by 32%. Now, it's mainly a Chinese study, and we needed further studies. It was a point study. Point study had the same intent, but the design of the point was different, right? They aimed for treating patients with 90 days. The chance study, they loaded Plavix, load was 300, right? 300 PO. The point is 600. So the patient comes in, minor stroke, TIA, 600 Plavix, 325 milligrams of aspirin, right? This study was halted because of risk of large, moderate large hemorrhage, systemic hemorrhage, right? It was halted. Data analysis after that revealed that there was a trend for efficacy in those patients who were treated, especially within 7 days, and the hemorrhage was the high risk for hemorrhage was found on the end of that window, right? So post day 20, right? So based on that, we have this ongoing debate, right? So a patient comes, we know it's a beneficial if we treat them with the antiplatelet, but should we load them with Plavix 300 or 600, right? So you look at Verify now, the assay for P2Y12, if you load the patient with Plavix 600, they'll become therapeutic in about 6 hours if they respond well to Plavix. If you load the patient with clopidogrel in 300, well, 8 hours. So it's a 2-hour window there, you know. And that was a question of one of our students or a resident yesterday. It's like, Dr. Falcao, why? Because I tend more personally to load a patient with 300, not 600. There's a colleague that does the other way, and there's an ongoing debate. It might be my bias, but neither way is currently wrong. We do aim to have the dual tablet therapy for 21 days, mainly to decrease the risk of hemorrhage, right? And then on the outpatient side, the chance study they used to drop, they was designed to drop aspirin, keep Plavix. We do the other way. We keep aspirin and drop Plavix because of cost reasons here. All right, so and because of those two studies, there are recommendation guidelines to treat those patient population that are eligible for this with 21 days. And this is also present in our other sets, right? So, all right, so just to make things more complicated a little bit, they will ask me, okay, Dr. Falco, but why sometimes you recommend aspirin and Plavix for 90 days, right? Do you know why? All right, so some patients, they are eligible for that approach because they have intracranial artery stenosis. It's another study. It was done comparing if the patients present with a stroke or a TIA for in the setting of intracranial significant artery stenosis. Should we treat them with medical therapy or should we stent them with a wingspan stent, right? That study was mainly aimed to answer that question. What we saw is that patients who received the maximum medical therapies like high dose statin, 325 milligrams of aspirin, 75 milligrams of clopidogrel, quit smoking, control systolic blood pressure below 130. That patient population had a positive outcome compared to the ones with the stent, if that is done for the period of 90 days. To the point that we saw that the risk of was a composite efficacy, right? And the defined by no stroke, no death within 30 days, right? So the stent arm saw about 14%. The medical arm saw a 14% reduction of stroke, while the stent arm saw a 5%. And the wingspan stent was associated with a risk of death of 2.2%, right? So there's significant evidence that the patient comes in found with arterial stenosis, we'll do medical maximum therapy first. If that fails, then the patient may be eligible for stenting, right? And that's the in a nutshell answer to the question. Why we do 21 days, sometimes we do 90 days. Once we're treating different etiologies, right? So let's pause here, okay? Go back to the case. So we got an MRI, right? The MRI shows that a cortical stroke there, right? So what is the likely stroke mechanism, right? Somebody wants to take a chance there, right? So whenever you have a stroke, whenever one of our patients suffer stroke, our goal is to take a look and say, hey, let's find the cause so we can prevent, not only treat that stroke, but prevent in such a way that we can avoid the patient from having further strokes, right? So there are different causes. I just mentioned the arterial stenosis. We have the small vessel disease, large carotid, large vessel stenosis, and cardiac embolic sources. This was merely very clear named by the TOS criteria at the it was a clinical study aiming to stroke etiologists, to name a stroke etiologist, right? So we have different types of breads. We all bread, right? Those, yeah. So they can be cardioembolic, large vessel, small, all right? So what was the cause of this, right? Embolic stroke of unknown source, right? The patient has embolic stroke, and you don't find a clear source. You have a vessel that does not show meaningful atherosclerosis. There's no arterial stenosis here. There's no AFib seen on tele, right? The patient who had a normal blood pressure. 30% of the strokes that we see are cryptogenic stroke, embolic stroke of unknown source, right? So, and that's when we cannot attribute the source of stroke. All right. This study was aiming to look at this specific question, right? So the design was to have a ILR, implantable looping recorder, on the patients, and compare to the patient population for those patients who goes to PCP, to readmit to the hospital, get EKGs. What is the risk of AFib of that post-stroke population with embolic appearing strokes, right? So the answer was that those patients at 6 months here, they had a 10% chance of finding AFib, paroxysmal AFib, compared to the cohort who did not have the implanted loop recorder. And you see this incremental. There was publication of updated data on the Crystal AF trial study that validates that and shows up to 3 years the relevance of having the implanted looping recorder. And that's one of the reasons that we, for patients with embolic appearing strokes, we discharge from the hospital with the goal to have at least the heart monitor halted for 30 days, right? We are still discussing and how can we develop a service in hospital to have a ILI implantable while the patients are here, because I think that would be the best approach. Okay, so the patient has a AFib, paroxysmal AFib. How do you treat, right? So it's customizable. It's a case specific. Most of them will benefit from direct oral anticoagulations, but it's depending on comorbidities. If the patient has a kidney dysfunction or has a history of intraperitoneal hemorrhage or other details, and all this can be used. This criteria can be used. Falls, right? This is a common question, the risk for falls. There was a large study done showing that the patient would have to fall 265 times a year to develop a subdural hematoma on anticoagulation. All right, now you see this, the patient is in hospital. Do we obtain a TT or a bubble study? Yes or no? No? All right, 65-year-old. All right. So PFO, right? To look or not to look for a PFO. All right. So here's our stroke. Same here. Let me see if I have another slide here. So the PFO, we usually use what's called ROPE score to assess for the probability that that stroke was caused by the PFO, and the PFO was not just an incidental finding. Okay, now let's change the age there, right? Let's say the patient is not 65, same comorbidities, but now it's 50. Would you get a PFO bubble study, a TTO bubble study, right? All right, so if there's a PFO, would you consider closure? All right, let's talk about that. All right, let's talk about that. We're gonna 5 more minutes. We'll go from there. So, looking at the PFO, there are 8 studies. If you look at PubMed search right now, there'll be 600 articles, but there are 8 landmark studies for a PFO and PFO closure. All right. Out of the 8, 7 of the studies require for the patient to have a stroke seen on imaging or in a PFO to have the patient undergo closure. Okay, so the question for TIA and PFO closure is unknown. There's one study from South Korea that showed positive trends with the TIA and a PFO, and that was the only study that included patients up to 80 years old. Right, that's the only study. So if you look at the design of these studies, the reduced trial and others important landmarks are for PFO. The risk of the PFO was defined of patients with PFO, and the risk was defined for large PFO, which is 20 to 30 microbubbles in 3 cardiac cycles and a right ventricle opacification seen on echocardiogram. right? So those patients were on age cutoff 60 and below, right? Having large PFO and no other stroke, obvious source of stroke. Right? So it's not the patient who have a carotid stenosis here of having a fib and a PFO. Those patients underwent the PFO closure. And you saw a trend when you look at the meta-analysis of all these studies, you saw a trend to the patients who were eligible for embolic stroke of unknown source, have the PFO closure, and you saw a trend of these patients to a efficacy on the closing the PFO. So the risk reduction in 5 years was 3.4% for those specific patient population. There was a pre-procedure complication rate of 3.9%. And you ask me, okay, what is the risk for having developing AFib long after the pre-procedure time, right? It's about 0.33% per year. Okay, now, and that's what we have to approach our patients is the discussion, right? Oh, okay, you have a PFO. The prevalence of PFO is what? 25% of the population, right? So you have a 4 here, one of them have PFO. So adult population. Now, is this PFO actually a source for the stroke? Is this the etiology of the stroke, right? And if so, if you thought so, should we close it? Okay, and the patient will ask, okay, if we don't close it, how should we treat it? Right? So the question is open, but we have some evidence to guide us through, right? There are 2 studies, the Navigate ISUS and Respect ISUS. Those studies were aimed to verify the safety and efficacy of treating patients with Navigate ISUS was dabigatran versus aspirin for embolic stroke of unknown source, and Respect ISUS was rivaroxaban versus aspirin for embolic stroke of unknown source. So there's a subgroup analysis in those 2 studies that looked into patients who had a PFO with embolic stroke of unknown source treated with anticoagulation. There was no benefit when compared to aspirin alone. And there was increased risk of bleeding for those patients who were treated with anticoagulation, right? So if you do not close the PFO and the patient is eligible to close, then my recommendation would be to treat patient with antiplatelets by evidence. Okay. Now there are exceptions to. There's always exceptions. So that's the evidence behind antiplatelets only. And also, there are questions that still remain to be answered, right? So if you're 61, if you're 62, you have no other embolic stroke unknown to cause that obvious source, should you close the PFO? Those are medical judgment questions. So any questions about the PFO before I move on? All right, it's like a cute picture so that people wake up at this time. It's hanging there. It's almost done. So this young man is shoveling snow, developed a right-sided face pain, then later has some difficulty with left hand, and it's been 6 hours, right? It's not good, right? It doesn't go away, keeps getting worse. Now you're moving, decreasing, losing movement of the left hand. The wife calls EMS. Patient comes to the hospital, we see a Horner syndrome, right? There's a right ptosis and anisocoria, and has a left side of weakness, right? Here's the MRI, right? So you have a Horner syndrome, you have a stroke, right? Who wants to guess the cause? I would pick other, but you can, all right? So it's a Horner syndrome as a carotid dissection, right? So I've had patients suffering carotid dissections in the context of so many things. Like jiu-jitsu is a very common one. King's Dominion, there's a specific roller coaster there. I have a gentleman going there 19 times and ended up having a vertebral dissection. Yeah, squatting with a bar. Oh, yeah. And if in the medical field, just be careful with playing tennis. I think I've seen so many of us having dissection plane tendons. But once you have a diagnosis, how do you treat, right? How do you treat? So old thought was that we heparinize all these patients, right? Put them on heparin drip, ICU, right? Should we try to open the carotid, the cervical vessel, vertebral carotid? Should we stent it, right? So the CARIS study was developed to answer this question, right? It's not a perfect study by any means, but is the biggest one we have to answer this question. And what we saw, we have those patients that was dichotomized to either antiplatelet versus coumadin. There was no difference between aspirin and coumadin for the cervical dissection, and we saw a recognition about 70% within 6 months. Right, so the lessons learned from this study was that if you see a patient with a dissection, look for another one. Right, is high risk of in a short time. Long term for a spontaneous dissection is very low. It's a 1 to 2%. Okay, now this is a type of pathology that I would involve neurology, stroke, and neurosurgery because it's not clear cut. You can have a dissection flap with a thrombus. You can have a dissection with a cell vessel wall edema that requires anticoagulation, right? So it's not that clear, right? Almost there. So let's change a theme a bit here. So a patient is a young woman and has the same type of stroke. What do you think in this context? Yeah, right? So in the internal medicine environment here, I find it very questionable to obtain hypocoagulable labs. I don't know if you disagree. I don't know if our hematology colleagues agree. There's some propensity to have a false positives, especially for antiphospholipid antibody syndrome that requires a specific time window of interval to obtain. And out of preference, we'll do it on the outpatient setting, right? So for those hypercoagulable state, I would have, if the suspected patient has a hypercoagulable state, I would definitely check the antiphospholipid antibody syndrome labs, which is lupus, anticoagulant, beta-2, glycoprotein, and anthracolipin, both IgM and IgG, right? So, and then you have hyperhomocystinemia, which has been correlated with risk for stroke, and unfortunately, treating that with vitamin supplements has not showed to be improvement, right? So let me give you some honorable mentions here of the question that you may have, and then I'll finalize, right? So let's say this patient here, right? They're not reading this. This patient here has EF of 30%, has no AFib, right? You don't see heart thrombus. How would you treat? Would you anticoagulate the patient? Yes or no? Who would? Please raise your hands, right? So this study was designed to look into this question, right? So the WARSAF study. So what we saw that for patients with EF of less than 30% and age of up to 6-year-old, beyond 6-year-old, there was the design of study. There was not a improvement of efficacy of anticoagulation compared to antiplatelet alone, and on the contrary, there was a higher incidence of hemorrhage. Okay, now what happened was after that study, there was a unplanned subgroup analysis. Now, when you do that, you have bias, right? But then there was unplanned subgroup analysis, and what we saw, there was a trend for a beneficial and improved outcomes of patients with age 60 and below with EF less than 30%, no AFib. That specific patient population they benefited from anticoagulation, right? It's a medical judgment for every single case, but that's the evidence that we have. And the anticoagulation at that time that was used was warfarin, right? And another one was that you have a patient with, let's say, an MCA stenosis. Would you treat the patient, let's say if this patient here has a left MCA stenosis, would you treat that patient with a anticoagulation or antiplatelet? So this study was was designed to look into that question. Right? Patients with arterial stenosis did not benefit from being treated with anticoagulation over aspirin in that trial. And I mentioned in the beginning the samples, right? All right, what are the questions? We went through so many studies, but
Thanks. What questions do we have here in the audience?
So on the, I guess, internal medicine side, we've been thinking a lot about cytochrome P450 metabolism and clopidogrel and how to think about what we should be using. Do you guys do testing for that, or with only 21 days, it seems like the results would come back and then it doesn't matter. But I don't know how you guys are thinking through that issue.
it was not part of the design of the study. No, we don't. We there's a debate right now on to use the verify now PY12 assay for Plavix clopidogrel response. We don't use cytochrome analysis for this. That was not part of the design. Do you guys use that?
I think some of the cardiologists are using it, or they use, Tucochlor or some other medicine to sort of try to get around that. But it's complicated because we have so many studies with Plavix that preceded where we are now.
Questions?
I think that the biggest debate that we have ongoing right now is PFO, right? Because it's become so constant. The question, should we close or not? Should we close or not? And it's a good debate.
Some team members from Tappahannock online. Anyone else? Okay, all right.
So this may be a bias of mine, but I drive by some of our other friends in the community, their hospitals, and they say certified stroke center. And I feel like we can do a lot more here for stroke patients than they can do at other places in our community. Am I wrong about that? I feel like with our interventional radiologists and expertise that we're ahead of them in terms of what we can offer with some of the technology.
I think our biggest quality here, we are the best, but we are very humble. So yeah, I think that to answer your questions is that from the comprehensive side of it, right? We have our team is extremely qualified in terms of training, and we are all in-house, and we beyond just the process here for that are validated beyond evidence. Beyond the use of evidence, we also have research ongoing. So you have clinical trials right now. You have at least 7 or 8 ongoing clinical trials that the patient can be eligible for a myriad of stroke-related comorbidities, right? I know Dr. Alatar is running a study called Sleep Smart, is looking to obstructive sleep apnea and stroke. So there are so many different studies that you can be part of it. Besides, they are single expertise. I do have a bias to answer that question too.
All right. Well, thank you so much, Dr. Falcao. We appreciate it. Thank you.
Oh, thank you.